We are
Hi.
here with Laura Madeline from the VA and some other people from the VA as well to talk about how, as hospice partners, we can better serve veterans and the flow of the VA's programming. So thank you, Laura Madeline.
Yeah, thanks for having us today. So, Laura Madeline Tebow, palliative care outpatient social worker at the VA, and I have some of our palliative care team on today. So, I'm going to put them on the spot and ask them to introduce themselves. Liz, can we start with you?
Hi, I'm Liz Soames. I'm a palliative care physician. I work in the outpatient clinic as well as inpatient consult service, and I do a lot of our work with our hospice partners to reauthorize hospice, add supplemental home care, and work closely with Laura Madeline in that.
And Morgan, can you introduce yourself as well?
Hi, I'm Morgan Unruh. I'm one of the palliative care physicians here at the VA. I work primarily on the inpatient side, and so we help coordinate discharging veterans from the VA hospital to home and occasionally to the inpatient care centers if that's what's the next step in their journey.
And Sarah's on our inpatient team as well. Can you introduce yourself, please?
Hi, I'm Sarah Osani. I'm the inpatient palliative care social worker at the VA, and I work with a lot of you all as well.
And Stephanie?
And my name is Stephanie Hartz. My area of expertise is rural and highly rural veterans throughout the Eastern Colorado healthcare system. And I also do remote geriatric care too for those same areas for veterans that need palliative care geriatrics.
Thank you
And just,
for being here.
oh, sorry. Just making sure you can see my screen. Okay, in the correct screen. All right. So we'll get started here today. And just a plug that, of course, I'd love for you to share this with your social workers, liaisons, admissions teams. And I am available to present to individual hospices as well. And I do offer this presentation in person. All right, so we'll get started here. We actually already kind of did the introduction section. So we're going to talk about different care pathways, frequently asked questions, resources, contact information, and we'll have time for questions. Becky is always great about sending out the recording, and I have quite a bit of resources, handouts, as well as this presentation to add to that email. So you'll receive all of this information once the recording is ready.
Thank you so much.
And we'll stop a few times throughout the presentation for questions. So if you have questions, throw them in the chat and Stephanie's going to help me make sure that I don't miss those when you screen share. Sometimes you miss some of that information. Let's see. So we've already kind of discussed this. I just want to just review that our palliative care outpatient clinic provides outpatient services, meaning that we're not doing home visits. So we're seeing veterans in our clinic or by video, you know, as well as our inpatient team. And in my role, I am providing social work services and case management services for our palliative care clinic veterans. I share that because that's new for this role. There used to be a lot more of administrative work. So that's one of the motivations for trying to streamline some of these processes. Very glad for you to share this with community partners, with new staff, but this is not information meant for veterans and families. It's too in the weeds, it's too detailed, and would probably be overwhelming. So, you know, we all know the challenges here. I'm working with a veteran. They need something. Who do I contact? What services can they get? How long is it going to take them to receive those services? Is waiting to hear back from the VA going to delay their hospital discharge? You know, you're playing phone tag, you're trying to do your case management between your hospice visits. My goal is to make this a better experience for everyone, for the veterans, for the hospice agencies. Y'all are our partners out there doing this for all of us as well, and to hopefully have, you know, quicker access to care. I'm going to start at the top because often I'm contacted for completely different branches of the VA, and that can just delay care because you're waiting for information from me that could be easily accessed elsewhere. So there are 3 branches to the VA, and everyone just refers to it as the VA. So we have the Veterans Benefits Administration, Veterans Health Administration, and the National Cemetery Administration, and we don't talk to each other. They're all separate systems. So we'll start with the Veterans Benefits Administration. When you hear benefits, think money, think income. Okay, so this is where people get their service-connected disability ratings. They might get a monthly pension, survivor benefits, burial benefits, as well as aid in attendance, which is an additional amount of income that they can use towards their care under certain conditions. I get emailed a lot for these things. I'm going to tell you what I do. I type in VBA, the name of the program, and as long as it's a .gov website, that's the information that I'm sending to you. So you can do that. Just make sure it's a .gov website that you're referring to. The main thing, like how do these veterans access these resources? Every county has a veteran service officer, and you can find that list at the link, or you can Google, Jefferson County Veteran Service Officer and find that information. That's a free service available to veterans and families in the community. So they will help them in applying for all these benefits. They know how to do this. This is what they do all day. And instead of the veteran or family applying and getting denied for accidentally filling out an incomplete section or something, the veteran service officer will help them and help them resolve issues with their claim. So I really encourage connecting them with that. There is also a national phone number that families and veterans can call as well. Then we have the Veterans Health Administration. So this is me, this is us, this is healthcare, this is hospice, our hospital, our community nursing homes, primary care, specialty care, and home health care. The biggest barrier for veterans, especially at end of life, is are they enrolled in the VHA? And that's something we're going to talk about today. I know that we can't always, sometimes we're doing reactive social work in case management instead of proactive, but when we can be proactive, the biggest gift that we can give to veterans and their families is making sure that they're enrolled and giving them the information to do so, which we are going to go through in detail. And it's really best if they do this in advance of a crisis. So we're going to go into the Veterans Health Administration in depth today. And then we have the National Cemetery Administration. This is your Fort Logan, your Pikes Peak National Cemetery burials, memorial flags, things like that. They have a very helpful website. They also have a phone number, and reputable funeral homes should be assisting the veterans and the families with this process. So we're going to get into the VHA. So we'll start at the top. You're working with a patient. You learn they're a veteran. You're going to encourage their veteran or family to call our main number if they're capable of doing so. Of course, sometimes you might have to assist them, have them on speakerphone. So the first thing we need to know is, are they enrolled in healthcare? So you can call and you can press option 2 to connect with their team. If they don't have a chart, then it's going to be, you're going to be sent to enrollment, which you can also call and press option 4 to check if they're enrolled. That goes directly to our business office. Let's really ask our veterans, to be partners in their care when they're able to do so, to learn this. So you found out that they're enrolled. The next thing you're going to need to do is, who is the point of contact for this veteran? What social worker am I going to be working with at the VA? So let's go down the yes category. Yes, they're enrolled and they have a primary care doctor at the VA. At the VA, we call primary care PACT, Patient Aligned Care Team. It's primary care. So you're going to call and you're going to ask, or the veteran or family is going to ask, please help connect me with my PACT, my primary care team, and the assigned social worker, because every PACT has an assigned social worker. That's the person that you're going to work with to get whatever services they need. We're going to go into services next. I also want to point out that If a veteran is at one of our community nursing homes and the VA is paying for them to be there, so it's not private pay or Medicaid, the VA is paying, then we have a community nursing home team that has a nurse and social worker, and that's the point of contact for that veteran. If you're a hospice agency and you aren't sure who that is, the social services department should be able to tell you who that is. So say you call and they're not enrolled. So the next step is really to provide those enrollment instructions and encourage the veteran and family to follow up. The information that's needed is beyond what you as a hospice team is going to have access to. Information about income, about dates in service, having a copy of the DD 214, those are things that the veteran or family are going to have to work with you on. And then once they are enrolled, me as the palliative care outpatient social worker, I'm the point of contact. I want to share that, previously this role helped a lot with enrollment. I have learned that about 95% of the people can, with a little bit of support from the hospital case manager, from the hospice social worker, from their family, can go through the enrollment process. I reserve getting involved for veterans who say are living at a hospital waiting on VA community nursing home end of life benefit and they have no family. That's the type of patient that I'm getting involved with for enrollment. Or they're living at an inpatient or GIP level care center waiting for these benefits so that they can have a safe discharge plan. It's not quicker to go through me. It's actually slower to go through me than to go through the enrollment routes that already exist, including our business office, because you're waiting for me to be available between the other demands and visits and such. And again, I have specific instructions to provide on the enrollment. I do ask that you try to identify the VA point of contact. If you can't, you can always send me a secure email and I'll go over what information is needed in those emails to us. All right. Should I pause there for questions or should I keep going into the services?
Nothing in the chat box so far, Laura Madeline.
All right. Thank you.
Is this a handout that you include when you email me?
The entire PowerPoint will be included, yes. And the enrollment instructions, yes. Definitely. Thank you. Okay, so let's get into it. This is very much into the details. These are the services. So first I'm going to go over what these services are and the timelines to obtain. I've also organized this information in a different way that might be easier for you to reference. And I think Stephanie can put that in the chat for us. I titled it like a cheat sheet because it's just an easy thing for you to reference when you're out in the field, save it to your computer or print it out, whatever. So often we get asked about supplemental in-home supports. So hospice is already in the home and the goal is to stay at home, but they need a little bit of extra care. So what this is a few extra hours a week of in-home care, hands-on care, and includes a little bit of homemaking services. This can take days to short weeks to obtain. In-home respite is 6 hours of care, 30 days per year. This also can take days to short weeks to obtain. Sometimes we get asked, can VA be the payer for hospice? This veteran doesn't have Medicare or they've elected to use VA as the payer. This is the same service. They should receive the same hospice services regardless of payer source. There really should be no difference for the veteran except for perhaps a little bit of lag time or administrative on the front part. So this can sometimes occur same day or can take days. That really depends on how quickly and thoroughly the information is provided to the VA. Also, our providers' availability to review the documentation provided between visits. Sometimes we're asked to authorize VA as payer for hospice, and the veteran hasn't been seen in 3 years by a VA provider. So we need a lot of documentation for typically Dr. Soames or one of our other providers to review. One thing that we're probably all very familiar with in the hospice world is the community nursing home benefit. So that's where the VA is the payer for the nursing home stay at one of our contracted facilities. Our contracts do change. This can take anywhere from days to weeks. I would say that typically authorization takes at least a handful of days, but it does depend on how thoroughly and accurately information is provided to us. How quickly does the nursing home respond to you? Do they have a bed available? Other veteran placement issues. We also have institutional respite, which veterans can use in addition to their hospice respite benefit, which is really excellent. So that's up to 30 days per calendar year of respite in one of our community nursing homes. And again, that takes anywhere from days to weeks to obtain. So now we're going to go through each of these services and talk about eligibility and copays for these services. So for unskilled home healthcare, they are eligible if they need hands-on assistance with 3 or more activities of daily living. It does not matter if they have a service-connected disability or not. It does not matter if they're on hospice or not. If they are on hospice, we do ask that hospice has maximized their services first. That's why we ask how many days per week the CNA is coming out. We want to see at least 3 days a week that the CNA is coming out to provide the care, which they probably are, because if you're asking for additional services, that's somebody with really high hands-on care needs. We are, if there's something unique, or if there's a staffing challenge, you can tell us those things. We can take those things into consideration. An example I can give is I was working with a community partner recently, and the nurse was going out 4 days a week due to wounds and unmanaged symptoms. So the CNA was only going out twice a week. That's a lot of hospice visits per week. And the nurse was providing some personal care when the nurse was already out there. So we'll take those things into consideration, but that's the ask, is to come to us after hospice services have been maximized, minimum of 3 days per week of visits. In-home respite also requires that hands-on assistance with care needs and a caregiver who needs a break. So this is not for your veteran who lives alone. This is not related to service-connected conditions. This is not related to if they're on hospice or not. Some veterans might have copays. Veterans on hospice do not have copays for this service. Let's see, VA is payer for hospice. It can have a slightly longer processing time. They do have the option of concurrent care, which Dr. Soames is going to speak to in just a minute for us, because that's a very interesting and nuanced topic. The agency must be contracted with the VA. Sometimes I see veterans wait in a hospital over a weekend who have Medicare, say that they don't contact us till 4 p.m. on a Friday and I'm in clinic, and community care doesn't work over the weekend. So I would just say, as a word of, veterans can use their Medicare, and sometimes in a pinch that can be a tighter, a quicker turnaround for them to get those services that they need. And the community nursing home benefit, we're so familiar with this. So there's multiple ways that veterans can be eligible. The main way that hospice agencies are worried about is that end of life benefit. So who's eligible for that? If they're enrolled in VA healthcare and they're on hospice, they're eligible for this VA contract, VA community nursing home end of life benefit. There's no copays. They continue to receive their income from Social Security or from the VBA. And hospice can be paid for by the VA, by Medicare, private insurance, it doesn't matter. They're eligible for that benefit. And then institutional respite, very similar to these others, not related to service-connected condition, have to have a caregiver, not related to if they're on hospice or not. If they are on hospice, they will not have a copay for this service. I think I will pause here for Dr. Soames to talk about concurrent care hospice, if that's okay.
Yeah. Any questions for Laura Madeline before I proceed? I don't see any in the chat. So concurrent hospice is essentially having your cake and eating it too. In the civilian world, we talk about the choice between hospice or continuing treatments. And at the VA, I mean, it's more than just having your cake and eating it too. Of course, you have to fulfill the classic hospice criteria. A, that you're medically eligible, you have a prognosis of 6 months or less, and you are hospice aligned. This is crucial. That your goals of care are aligned with maximizing comfort, avoiding rehospitalizations, prioritizing comfort and quality over longevity. And so you can enroll in hospice with those criteria, and the VA will continue to pay for treatments as long as they are intended to improve quality of life and be palliative intent. A great example that Laura Madeline brought up yesterday was, someone with head and neck cancer who's undergoing radiation so that they can maintain their ability to swallow, to reduce the tumor size and, help with that quality of life aspect. So that's a perfect example of concurrent hospice care. Or perhaps someone who has, some sort of blood dyscrasia. They require ongoing transfusions, and those transfusions help them feel better. But it's not necessarily extending their prognosis, that it's still 6 months or less, perhaps a little, but it still doesn't mean that they're not hospice eligible. And so that's another sort of caveat that can be tricky, is that these palliative treatments are not going to significantly extend their prognosis, that it's still 6 months or less. These two examples are pretty cut and dry, and in the real world, they're a lot more complicated, a lot murkier, especially as goals of care can be sort of not fully hospice aligned. So it's really essential to talk about these cases on a case-by-case basis. And I'm always available if there's, for folks who are enrolling in hospice and wanting to pursue these palliative treatments, whether it's truly in the spirit of concurrent care, I'd be more than happy to talk through these cases with anyone who's interested in them. So it can be tricky, and we want to help people navigate this and continue. We can sometimes continue to liaise with hospice agencies, especially if the palliative treatments are outside of the VA in the community. It kind of takes a lot of, getting on the same page, everyone understanding what the goals are, what the treatment plan is. So, as that palliative intent treatment is being pursued, we can help navigate.
Thank you. Yeah, I think the thing to highlight, it ends out being case by case. And maybe Dr. Soames, you could put your email in the chat. And then also you can always reach out to me by secure email, and we can get going on these conversations if needed. Concurrent care is not a discharge planning solution. If a veteran is in a hospital and isn't hospice aligned, it can't be like fudged or forced. It really has to be truly appropriate, truly aligned. I also want to add the community nursing home end of life benefit is also not a good discharge planning solution for a veteran who's just kind of stuck in a hospital. I recognize that happens, and there's a lot of pressure sometimes to get people out of the hospital. But if they're not truly hospice aligned or hospice eligible, it ends up putting them, the hospice, the nursing home, us, the family, kind of everyone ends out in a bad situation. And there can be a lot of upset community partners and customers that we want to keep good relationships with. Because if the veteran signs off of hospice, graduates from hospice, no longer needs nursing home care, then they don't have a payer source for their nursing home stay unless they meet one of the other conditions listed, like related to service connection. So just something to kind of be aware of if you're working with a veteran who the VA is paying for their community nursing home under the end of life benefit, and you start hearing your nurse case manager, your medical director, and IDT meetings talk about stability, possibly graduating. Let's be really proactive and make sure that we're doing some good coordination with the social services at that nursing home and the community nursing home team around other payer sources, like applying for Medicaid. That's when I can see kind of getting tricky.
I have a question, and if it's a tangent, just tell me. We'll talk about this another time.
Yeah.
But I'm curious, with concurrent care, there's is mental health part of that? Like, can you have concurrent care if you come across somebody and you notice as they approach end of life, moral injury is really, a lot is coming up for them and they need a heavier lift of mental health services? Does the VA help with that, or should that just come from the community partners access with our own social workers and chaplains? But I recognize the VA probably has people who specialize in things like moral injury or post-traumatic stress injury. So I was wondering about that.
That's such a good question. I honestly haven't ever encountered that, but I can see it happening. I mean, to answer your question directly, I think, of course, you would want to maximize the social work and chaplain support as much as possible. But if there are, I think, especially if a veteran has been established with mental health at the VA, that would be a really good, concurrent hospice care with continuing to see those mental health providers would be an excellent use of concurrent care. A new referral to mental health, I mean, I would absolutely consider it. I think especially if those like the your first frontline supports are aren't quite meeting the needs. If there's more psychiatric needs, then we would be happy to consider a referral. We do like start new care within the VA when someone's enrolled in hospice when it's appropriate. That's precedented. Yeah.
Thank you. That's really good to know. I appreciate that.
So I'll keep going on this. So a lot of times people want to know, like, okay, so here's the services, here's what they are, here's who's eligible. What do you need from me? What is my point of contact that I've identified need from me? So I have all that listed here. You'll note that sometimes we need a lot. Like sometimes we don't have information on this veteran. We need the certificate of terminal illness. We need IDT notes. We need their hospice admission H&P. Like sometimes we need a lot of information, and sometimes we have a lot of information and don't need as much. So your point of contact is always going to be the one to say, here's what exactly we need. But I have gone ahead and listed this out. I do want to highlight that if they're asking for supplemental in-home support, so the unskilled home health care and the in-home respite, and they don't have a VA primary care provider, we need a lot of that information, and I help coordinate that. And then Dr. Soames does these quick video visits. They're like 15 minutes, and it's just so that we can fulfill that face-to-face requirement so that she can write orders having seen the veteran in the last year. And we do ask our hospice partners to help us facilitate that. So when somebody's working with me in that process, and it will be me because those are the unassigned veterans, then we send them instructions on how to schedule. So we do ask for the hospice social worker or nurse to be present and to actually facilitate that visit from their work phone or work computer. It just takes away the stress of like a new video visit for the veteran and family. Those are very quick. We hope they're not a lot of burden for, this great service. And again, the supplemental in-home support is exactly that. It's never going to be 8 hours of care a day. It's not going to be 24 hours a week. It's not going to be overnight. It's just a little bit of extra care. And then under the VA as payer for hospice, sometimes if eligibility isn't clear, then our providers will need to talk to another provider about those goals of care and eligibility. I do want to point out under the community nursing home, the hospice social worker is the lead. So our role at the VA, whether it's me or another social worker, is to get the documents and to get you that VA authorization, the VA basically payment that they're eligible for this and that we're going to pay for that. The hospice social worker is responsible for sending, or the hospital case manager, sending the referrals, getting an accepting bed, arranging all of the other transfer details, just like you do for all the other patients that you serve. We have to know the facility accepting date and when. We can't backdate it. Again, this takes a handful of days. This is not a same day type of approval. Once they are admitted to that community nursing home, we have a VA community nursing home team that becomes the VA point of contact for coordinating care from there. I'm going to go over two other programs briefly, and then we can pause again. So these are more programs that you might hear veterans already being on. I say that because the timeline, they're kind of administratively heavy up top to get going. So a lot of times the timelines don't align with hospice patients. And I try to be honest about that. But you might hear, oh, well, I get paid to be their caregiver through the VA. So that would be through probably one of these two programs, the Program for Comprehensive Assistance for Family Caregivers or the Veteran Directed Care Program. And some of that information is listed here. Both programs prioritize hospice veterans, but there are just kind of the regulations that they have to go through. These are great programs for those who are already on them or who might have a little bit of a longer timeline. So just wanted to check in. That's a lot of information on services, a lot of detail just to see.
What's the best way to get the updated? You said your contracts with nursing homes change a lot. So what's the best way to get the most updated who the VA is paying for? Yeah.
Yeah. So the VA point of contact that you've identified. So part of the materials that'll be sent out to the group is our most recent list from February 27th. Anytime you're working with a VA social worker, it's definitely, hey, can you send me the updated list just to make sure the one I have isn't old? Definitely not a problem, or you can reach out to me and I can send that. But whoever you're working with is the one who can provide, because some of these forms change too. So I always err on the side of like sending a lot of copies, a lot of things attached to an email versus none, but definitely great to reach out on that. Okay. These are just a list, just to remind me, these are all the documents that'll be sent out. So you'll get the matrix, that form that we use, the community nursing home referral form, the nursing homes, a brochure on concurrent care, enrollment instructions, which we'll go over, the cheat sheet that Stephanie shared, and a brochure. So I just wanted to share the matrix. This is something that we use to make sure that we get the documents that we need. A lot of y'all are familiar with this, and there'll be more improvements coming. So I don't know. Do you think it's helpful to work through an example? Or just, yeah? Okay. So let's say that you are a hospice social worker and you're wanting supplemental in-home care. So you would fill out the top, your information always, and then you would go down to section 2 and you would want to say, yep, for unskilled home health care and in-home respite. I'm going to say go for both. Like if you're already going through the process for unskilled home health care and they're appropriate for in-home respite, like they have a caregiver, go ahead and put it in there. Go ahead and like request it. That way, they don't have to like go through the process again or send in additional information. If they don't use it, that's fine, no harm. So you'll check those and you'll make sure that you're providing this information. Hospice admission, recent RN note, really great if it documents some of their functional status, like their mobility, their ADL care needs. The certification of terminal illness, go ahead and list the 3 ADLs that they're dependent in. It does not count IADLs, which is the independent activities of daily living. So we're talking about bathing, dressing, grooming, toileting, mobility, and transfers. We're not talking about laundry, meal prep, and medication management and transportation. And then we do go ahead and ask for the number of visits per week right there. And leaving these things blank or not including it kind of like delays the care because there's a little bit of back and forth there. Another one that comes up a lot is you're a hospice social worker and you're seeking VA community nursing home end of life benefit. So you're going to fill out the top always, and then you're going to say, yep, hospice in a nursing facility, referred to Holly Heights, admission a week from now. So you'll put that information in there, and you're a hospice agency. So you're going to make sure to include the hospice admission information, the CTI, recent team notes, in the hospice diagnosis, So that's information that you would include for that. But you can always ask, hey, is this information, what do you need from me? Is this all the information? Okay. And then here's the enrollment instructions. So this can be provided to veterans, family, anybody, hospital case managers, hospice teams, anybody this can be provided to. One of the challenges or slowdowns for veterans enrolling is not having access to their DD-214. They do need that for burial benefits as well. So it is, it is good to encourage them to do that. So if they don't have it, they can request it online, or they can have the veteran service officer for their county assist them with it. Really can't, until they're registered, we really can't do anything. We don't have like a chart for them. We don't have information for them. I can't start getting approvals until they're registered. So that's a really important thing. And if we can do that, like when they answer, as we honor veterans, you're asking if they're veterans. When they answer, this can be like hopefully part of that conversation, making sure that they're enrolled and kind of present it. I understand people have feelings about getting care at the VA or, different experiences. Present it as a just in case. Hey, just in case you end up needing some nursing home support or some extra support in the home, let's go ahead and get this done versus having it be a crisis. Because unfortunately, just because it's a crisis there's not another way to get their DD-214. There's not another way to get them enrolled. Sometimes we get asked, sometimes veterans get told by enrollment, oh, you're over income for enrollment. If that happens, reach out to me because there is an option that applies to a lot of our hospice veterans. It's called catastrophic disability. Think of it as the backup to the backup plan. So, certain veterans that are legally blind, have certain types of amputation, have really high ADL care needs. And that's kind of the category that I think some of our veterans on hospice fall into. We can get it to where the income basically doesn't count and they're like exempt and can still enroll in healthcare. As it sounds, this adds days to weeks to getting approval. But we can, go through the process together and get the catastrophic disability so that they can be enrolled, so that they can access, for example, community nursing home end of life benefit. So that's just a word, just kind of in the back of your head, catastrophic disability, over income. I should reach out and ask some more questions. This is the main number veterans can call to make appointments, to ask questions about eyeglasses, to see their primary care doctor, to get connected with mental health. This is the main phone number. This is what they call. Same number you call to find out about enrollment or the team. Hospice, y'all are in the home. Y'all are seeing the veteran and family. You're the lead on that veteran. Sometimes we get asked about DME and supplies. Those come from hospice. And then we discussed current care. Going through this quickly today. Okay. So this is best practice for reaching out to anybody at the VA, is to have this information available. I know we don't always have the last four, and that's okay, but we do need the veteran's full name, preferably last four, date of birth, your name or the agency name, callback number, and a brief description of the need. So whether that's a secure email or a voicemail, this is best practice. I typed in a name the other day. It didn't seem like a common name to me, and there was like 5 veterans by that name. So then I'm like, I can't answer your question. I can't help you. And it ends out creating like a back and forth. Personally, I really prefer secure emails, kind of due to the volume of requests that I receive. It allows me to be able to like triage needs, respond between visits and meetings. And often paperwork is needed, so it's nice to do secure emails, but you can always ask your point of contact that you're working with on that veteran, what's the best way to reach them. Let's see. Things that slow down is is not including a veteran's name and asking a question because it's so specific. Are they enrolled is the first question. I really can't answer if I don't know if they're enrolled because I don't know their name. Are they in our catchment area? There's just things we can't answer if we don't have that. So like, hey, call me when you can. Those types of messages without a veteran's name, that kind of slows things down. All right, I will stop. Oh, there's my contact information. I'm gonna stop presenting and check in. I went through that all very quickly today, so I'm gonna see if there's questions and ask the team to jump in on things that you maybe wanted to add.
I'll just jump in, Laura Madeline. If it was too much of a teaser to wait for the CNH list, I did put it in the chat box.
Thank you,
I'm
Stephanie.
curious if you can remind us, a lot of our partners are work with hospice and palliative. And I know that the matrix you shared was for hospice specifically. There were some services that you didn't have to be on hospice to receive. I know the VA has its own palliative program. And if I was a veteran, I mean, everyone I've met through this has been just amazing. I think you offer really great care. And Jill too. I don't know if she's on today, but I've just been so impressed with everybody we've met. But would it be helpful if we receive somebody on palliative services and we, everyone makes their own choices and has their own agency, but encourage enrollment at that point for the just in case, go over those benefits that they could potentially end up with, and what benefits could
Yes.
they have before hospice?
Yes. So yes, encourage enrollment. Like you meet a veteran who's your neighbor, encourage enrollment. Okay. You meet somebody at the grocery store, enroll. Yes, absolutely. And then the only benefit that's really specific to hospice is if they're non-service connected. So they're not traditionally eligible for community nursing home. So they don't fit those other criteria of the 70% or higher or the 60% unemployable or the service connected disability is the need for enrollment. So say, like, I'll just give an example. Say they're like 20% service connected for Parkinson's disease, for example, and that's why they need community nursing home placement. Okay. So if they don't fit those and they're not on hospice, that's the only program I can think of that isn't relevant for them because veteran-directed care, program for comprehensive assistance for family caregivers, unskilled home health care, in-home respite, and institutional respite. You don't have to be on hospice. The only one that's like, are they on hospice? Is they're not traditionally eligible for community nursing home? Then the question is, are they on hospice so they can use that end of life benefit? Because you can't use the end of life benefit for just palliative care. It has to be hospice. That question comes up sometimes. Oh, well, if they sign on to palliative with us instead of hospice, can they still use that? No, it's really for that hospice population.
But they could use the respite benefit of, it
Yeah.
was like 30 days a
Yeah.
year, something like that. Okay.
Yeah.
And I had another question that was around that. What was that? Oh, if they get enrolled, can they still use their own PCP? Do they have to then?
Yeah.
Okay, so I feel like some
Yeah.
people are afraid they'll lose a team that they know and trust, and so then they
That's the
don't know
great
as well.
thing. That's the great thing about the VA. We have veterans use like Kaiser or their own PCP. It's great if a veteran, isn't in that hospice category. Maybe they're just your neighbor, your friend, or they're palliative care. Maybe they have a longer life expectancy. They can enroll, they can see a primary care provider. I think they have to see them every 2 years to not kind of fall off of their panel. But it's great to have a provider at the VA who can write orders for you. Because as we all know, there are things available at the VA that you can't get elsewhere. I'm thinking of like our wheelchair clinics, some of those like specific in-home respite. You don't get that from Kaiser, for example, or just traditional Medicare. So you can get a VA provider and just kind of see them once a year, once every other year to maintain having somebody at the VA who can write orders for you. Yeah, I definitely encourage that. There's no harm in doing that.
Thank you.
Do we have other questions, or does the team want to jump in? Oh, we didn't talk about this, or
I think you covered a lot, Laura Madeline, but as the VA, we are a huge, ginormous healthcare facility. So there's always things that aren't covered, but there's other great resources. So I've been getting all my neighbors out here enrolled in the VA just so they know about the healthcare. So just, I think that's a great plug. If any veteran is ever interested in VA services or resources, to do it before it becomes a crisis, and to get integrated in. So that's a great plug, and I think really that's a good takeaway too, just in general, is we can help our veterans if they're enrolled in healthcare and provide that.
I heard this, and maybe I can't remember where I heard it, so hopefully it's real. Is it true that the VA covers some integrated therapies like craniosacral therapy or healing touch, things like that? Is that acupuncture? Is that made up?
So we have, yeah, I'll take that one. It's not made up and it's pretty awesome. We actually have in-house acupuncture and in-house chiropractor. And then we refer to the community for, I believe it's biofeedback, hypnosis, and massage therapy.
That is awesome. So
Mhm.
if we were working with a patient in palliative care and thought that they would benefit from something like that, they could have their own PCP in the community, but also use the VA for chiropractic care or one of those other integrated.
If they're enrolled and that is felt to be an essential part of their care and their management of their symptoms, I think that's a good use of the concurrent care model.
I wish other healthcare insurance would cover those.
Yeah.
It's so smart.
Mhm.
that's really cool. Maybe that would be a good motivation to help people enroll. There has to be
Right?
some
Massage, free
motivation.
massage. I would do it.
Well, Laura Madeline, the time you spent on this is evident. Thank you so much for creating the flow charts and providing all the information and making it so that we, the clinicians we work with on our teams can have that in their back pocket and refer to it, and really appreciate it. Thank you so much.
Yeah, you're welcome.
Okay, I will stop the recording.